Hello and welcome to the Paediatric theme. This video is about meningitis in babies and children. So let's start by seeing what we already know. So question 1 is, which of these is not a classic symptom of viral meningitis? So is it fever, photophobia, neck stiffness, or a rash? So remember here that the question is about viral meningitis specifically. So the answer is rash, because this presents in one particular type of bacterial meningitis, whereas fever, photophobia and neck stiffness are present in bacterial and viral meningitis alike. So question 2 is, what is the classic sign of meningococcal disease? So is that a non-blanching rash, photophobia, neck stiffness or septic shock? So remember here that meningococcal disease is one particular type of meningitis. So the answer is non-blanching rash, which appears when the meningitis is caused by a bacteria called Neisseria meningitidis. So the final question before we begin is, which of these viruses is not a cause of meningitis? So is that adenovirus, Epstein-Barr virus, norovirus or enterovirus? So here you need to think about a virus that you'll know which causes a really common childhood illness. So that, of course, is norovirus, which causes the winter vomiting bug, not meningitis. So today we're going to cover an overview of meningitis in paediatrics. So I'll go over what it is, the symptoms it presents with, the investigations and differential diagnoses, and also some tips about histories and examinations. We will then finish with a few more questions. So meningitis describes inflammation of the meninges, which cover the central nervous system. It's usually a result of bacterial or viral infection and sometimes fungal infection. So the main bacterial cause in babies under 3 months is group B strep or E. coli. And then in babies between 3 and 6 months, it's usually Neisseria meningitidis, strep pneumoniae or Haemophilus influenzae. And then in children over 6 months, it tends to be either Neisseria meningitidis or strep pneumoniae. So as we discussed in the question, the main viral causes are enterovirus, EBV and adenovirus. The mumps virus can also cause meningitis, however this is now really rare due to the MMR vaccination programme. So classically, meningitis in adults presents with headache, neck stiffness, fever and photophobia. But in paediatrics, it's not that simple. So it often progresses to sepsis, so we should look out for signs such as tachycardia and hypotension. And the classic symptoms I just mentioned are sometimes described by older children, but babies obviously can't tell you things like if they have a stiff neck. And so signs to look out for are quite generalised. They may present with signs such as fever, irritability, poor feeding and drowsiness, and the other ones mentioned here. So remember to look out for the petechial or the purpuric meningitis rash. If this is seen, the child has meningococcal disease, which is meningitis caused by Neisseria meningitidis specifically, and it's likely to progress to meningococcal septicemia. So when taking a history from a child with suspected meningitis, remember to ask the parent or guardian about the non-specific symptoms we just mentioned. And also in babies, ask about delivery, and if mum had any infection at the time of the baby's birth. If the child is old enough to talk, ask if they've complained about any of the classic symptoms. Also ask about timing, as a quick onset of symptoms is likely to be meningococcal disease. So when investigating meningitis, bloods are taken for FBC, glucose, ABG, CRP, coagulation, UNEs, LFTs and blood cultures. Other cultures can also be useful, such as sputum culture. You can do PCR testing if you suspect a viral meningitis, but the most helpful test is probably a lumbar puncture, so we'll discuss that in a moment. Also, these brain scans can also be helpful. So, lumbar punctures. So they're used to measure the levels of various substances in the cerebrospinal fluid. So the appearance of the CSF is noted, and also the amount of white blood cells, protein and glucose is measured. So in general, bacterial meningitis will have more extreme CSF changes than viral. So meningitis results in raised white blood cells and proteins and less glucose than there is in the blood. So a lumbar puncture should not be done in certain circumstances. So these are if the child has cardiorespiratory instability, any focal neurological signs, coagulopathy or thrombocytopenia. Also if there's any local infection at the site where the lumbar puncture would be done. It also shouldn't be done if the child has any signs of raised intracranial pressure, which are coma, high blood pressure, low heart rate or papilledema. Also don't perform a lumbar puncture if this causes delay in starting the antibiotics. So the most important differentials to rule out when diagnosing meningitis are encephalitis, which is inflammation of the brain itself but presents very similar to meningitis, and also sepsis because this could be down to a different infection and not meningococcal septicemia. And then here is a list of some other conditions that may also present in a similar way, so should also be ruled out. So on examination, it's quite difficult to examine a child with suspected meningitis, especially in babies, but in older children it can be quite useful. So these are some signs you should look out for. So the Koenig sign is when the child is supine with the hips and knees flexed, there's back pain when you extend the knee. And the Brudzinski sign is when the child is supine and the neck is flexed, the knees and hips also become flexed. So if either of these signs are positive, meningitis is highly likely. So then some OSCE tips. So we've already covered tips about histories and exams, but just remember when taking a history, it's important to ask about the time frame and the non-specific symptoms, and also just like in any other paediatric history, ask about the immunisations to rule out any other possible infections. And then as we've just covered, remember to test for Koenig and Brudzinski signs on examination, but you can also gain a lot from general inspection if the child just seems generally unwell. Also, if asked to interpret a lumbar puncture in an OSCE, remember that mildly abnormal results are likely to be viral, whereas markedly abnormal results are likely to be bacterial. So then to finish the meningitis topic, we will go through a few more questions. So first of all, which age group would group B strep be likely to cause meningitis in? So is that infants under 3 months, infants between 3 and 6 months, children over 6 months, or teenagers? So a clue here is that group B strep causes many serious illnesses in this particular age group. So the answer is infants under 3 months, because group B strep doesn't tend to affect children older than this. So question 2 is which of the following would not be a finding on an LP of a child with bacterial meningitis? So is that raised white blood cells, clear CSF, raised proteins, or decreased glucose? So remember here that bacterial meningitis affects the CSF very significantly. So the answer is clear CSF. So the CSF would be clear if it was uninfected or if it was infected with viral meningitis, but in bacterial it will become turbid. So finally, which of the following children would you carry out an LP on? So would you carry out on a child with a high blood pressure, a child with focal neurological signs, a child with a low heart rate, or a child with a temperature above 39 degrees? So remember the list of contraindications we talked about. So the answer here is a child with a temperature above 39, because having a fever doesn't affect the ability to perform a lumbar puncture. Focal neurological signs is a contraindication, and high BP and low heart rate are signs of raised ICP, which is also a contraindication. So thank you for watching the video on meningitis. I hope it has been helpful.